First, we are going to discuss a little bit about some of the gaps in hepatitis B treatment in the U.S. And I'd like to just share two studies that have been published within the last few years. First, on the left here comes from the NHANES survey, and this was from 2013 to 2016. But in this survey, what they did was they looked at those who came in and tested positive for hepatitis B surface antigen. And then through that, they estimated the number of adults aged greater than 20. But what they found was, that of the people who were surface antigen positive, just 36% were actually aware of their infection. And of those 36% of individuals who were actually aware that they were surface antigen positive, just 28% of these individuals actually had initiated treatment. So again, a substantial drop-off in the cascade of care of the patients we see in our clinics. When the Hepatitis B Research Network started enrolling patients, they published their overall experience, and this is shown in the right graph here, where they looked at the cumulative probability of treatment initiation from enrollment. And so what they identified were substantial disparities here in those who actually initiate therapy. So you can see here on the y-axis, cumulative probability of initiating therapy. Asians were much more significantly likely to initiate therapy than were other groups, including African American, Black, whiter. And this was actually statistically significant. So again, we need to have awareness and consistent guidance available to us to help move forward and treat and diagnose these individuals with hepatitis B. Part of, I think, the confusion with hepatitis B is the phases of chronic hepatitis B, which over the years it has been evolving. And so the current phases are defined here on this slide. So you can see here that we have individuals at the top who go through a hepatitis B e antigen positive or infection, or known as the immune tolerant phase, with a high viral load and a normal ALT. We have hepatitis phases in the e antigen positive and e antigen negative groups here. And again, they're really just distinguished by two features. Number one, presence or absence of e antigen, but also the viral level. And in general, we find that the DNA level is higher in the e antigen positive groups. These hepatitis B states are associated with a moderate to high risk of disease progression and thus treatments indicated. And this is unlike the immune tolerant phase or those with very low HBV DNA and normal ALT levels. It's because of these definitions that the Liver Society guidelines have evolved to make their hepatitis B treatment indications. And we show you here the three major societies, AASLD, the Apostle Asian Alliance, as well as the European or EASL recommendations here. And what you can see here at the top are the hepatitis B e antigen group shown here at the top, that the HBV DNA generally needs to be above 20,000 international units, and the ALT needs to be above 2 times the upper limit of normal. And if these are present, then treatment is warranted for hepatitis B. The EASL guidance also incorporates a liver biopsy here, and if you do see moderate inflammation, necroinflammation, fibrosis, that this is also another indication for treating with HBV DNA levels that are 2,000 and ALT above the upper limit of normal. In the antigen negative, it's similar. You can see there's some variation here in the HBV DNA levels here between societies. AASLD 2,000, Apostle is either 20 or 2,000, but it's the same. But it's the same approach. And again, normal ALT for both societies are also listed here at the bottom here with a differential in ALT for the AASLD. So let's take another poll here. So which criteria do you currently follow when determining which patients are candidates for treatment with hepatitis B antiviral therapy? So we have here choice A, liver societal guidelines. This can be AASLD, Apostle, or EASL. We have the World Health Organization. Another guideline that's not listed, is it a shared decision-making process for each patient, or are we universally treating all patients with hepatitis B? So let's take a few seconds to vote. And we can see here that the majority of individuals 59% derive their treatment decisions from societal guidelines, a small percentage from the WHO, and then over a quarter of individuals makes this a shared decision-making process with the patient. So let's now talk about some of these individuals that the guidelines don't cover as well. So first, we're going to talk about the risk of hepatocellular carcinoma. And this was a very interesting study that was published, a multi-center analysis of individuals who developed hepatocellular carcinoma. This was a group of 3,600 individuals with chronic hepatitis B not receiving antiviral therapy, but that's because they didn't meet societal guidance. And of these 3,624 individuals, 161 did develop hepatocellular carcinoma. And the investigators went and they looked and tried to find out of those who developed HCC, how many of them did not meet the treatment criteria based on societal guidances. And you can see here that the percent of individuals here is substantial. 46% didn't meet AASLD guidance, a third didn't meet EASL guidance, and 2/3, or 64%, did not meet the APOSTLE guidance. And so one of the major complications of hepatitis B is hepatocellular carcinoma. We know that treatment reduces the risk, and a large proportion of individuals who develop HCC do not meet our current guidances for antiviral therapy. Let's also talk about the gray zone. And so we discussed the various phases of hepatitis B, immune tolerant, immune active, where we treat individuals. But what about these individuals who do not fit into any of these clinical phases? So this is up to a third of individuals. And as an example of one of these groups, it's those with hepatitis B with DNA levels above 2,000 international units, but the ALT is normal. And we see these patients commonly in our clinic. Our current guidelines have no recommendations for antiviral treatment in these populations. So the question is there a benefit? And this was a recently published paper in Hepatology. This was a retrospective cohort study of 855 treatment-naive patients with chronic hepatitis B without advanced fibrosis, and they were in the indeterminate phase, and these came from centers in the US, Europe, and Asia. The indeterminate phase here was defined as not meeting the standard criteria for immune tolerant, immune active, or inactive chronic hepatitis B. And you can see here in the graph here, they matched these individuals. And then in this cohort study, they looked at the cumulative HCC incidence over a total of 15 years. And what you can see here is that in the untreated group here, shown in blue, that there was a substantially higher HCC incidence compared to those who received treatment. And these individuals were matched for various demographic and other factors here. So you can see here over 15 years, particularly after approximately 5 to 10 years, you can see here the risks of hepatocellular carcinoma go up in those who are not treated for chronic hepatitis B. And thus the authors conclude that in those in the indeterminate phase or gray zone, antiviral therapy reduces the risk of hepatocellular carcinoma. In this cohort, the risk reduction was substantial. It was by 70%. So we have many reasons that hepatitis B can contribute to hepatocellular carcinoma. It can do so by the inflammatory and fibrotic mechanisms, and these are common to all of our chronic liver diseases. There are hepatitis B proteins, including the hepatitis B X protein, which is a transcription factor required for transcription for CCC DNA. And this protein is involved in multiple mechanisms, which are shown here, including tumor-promoting inflammation, proliferative signaling, angiogenesis, and a variety of other processes. In addition, hepatitis B DNA integrations is another consequence of chronic hepatitis B infections, where you have this insertional mutagenesis, and this can lead to dysregulation of cancer-associated genes. This can lead to also chromosomal translocations, and all of these mechanisms contribute to an increased risk in hepatocellular carcinoma. And now there is emerging evidence showing that treatment can actually reduce some of these processes and thereby providing a potential mechanism whereby an explanation whereby treatment actually reduces the risk of hepatocellular carcinoma. So this was a study that came out of Asia, and in this particular study, they looked at 28 Chinese individuals with chronic hepatitis B who were treated with antiviral therapy. And there were a cohort of 28 individuals treated for 1 year, and then 7 individuals were treated to year 10. And the authors were able to get biopsy data, and they were able to measure the number of integrations, as well as estimate the hepatocyte clonal size. And so clonal expansion is another mechanism of hepatocellular carcinoma. And what they were able to show here is that over a 1-year period on hepatitis B treatment in these 28 individuals, that there were statistically significant reductions in integrations and in the maximum hepatocyte clone size in those who received antiviral therapy. Then on the second row here, you can see that 7 of these individuals were treated out to year 10. And they were able to show there that there was a trend toward reduction in integrations and a reduction again, further reduction in hepatocyte clonal size again from baseline. And these reductions in integrations and clone size with antiviral therapy were present in both e antigen positive and e antigen negative individuals. What about outcomes in untreated individuals with e antigen positive hepatitis B, the immune tolerant phase, versus treated e antigen positive chronic hepatitis individuals? This was a study from Korea. This was a retrospective cohort of over 3,000 individuals, all of whom had DNA greater than 20,000. And again, in an immune tolerant untreated population compared to an immune active e antigen positive group, there were lower rates of hepatocellular carcinoma. There were lower rates of death or transplantation in the treated groups. And thus, HCC and unnecessary deaths can be prevented by treating an earlier antiviral intervention in selected individuals who are e antigen positive. So the strategies for how we approach hepatitis B are, if you will, somewhat different between different societies. As an example, the AASLD, they treat individuals, and there's a recommendation to treat if greater than age 40, and you have a liver biopsy showing significant necroinflammation or fibrosis, and thus hepatitis B here is treated as an inflammatory disease. The European guidance is a bit different. So in their most recent recommendation, 2017, they noted that if you're greater than age 30, regardless of the severity of liver histology, if you have a high viral load, you can be treated, and this is thus treated as a viral infection. So we're going to ask now another follow-up question. So compared with not treating, is there evidence that HBV treatment benefits patients in the gray zone? The answers are A, yes, higher virologic response, but lower liver-related outcomes. B, yes, lower hepatocellular carcinoma risk. C, no benefit was shown in studies. And D, no data available. Let's vote. Okay, so yes, and you can see the vast majority of individuals chose the Huang paper demonstrating that there was a lower hepatocellular carcinoma risk for those who were in the gray zone. Very good. So, and this is based on current data compared with patients who did not receive treatment. Those who received antiviral therapy experienced higher virologic response rates, fewer liver-related events, including HCC, and the overall reduction was 70%. So I'm going to then just emphasize here some of the key take-home points about guideline recommendations and limitations. So hepatitis B treatment uptake is suboptimal. Number 2, societal guidelines differ, but most recommend treatment with elevated HBV DNA and elevated ALT levels. However, people in the indeterminate phase who do not meet treatment criteria are still at risk for hepatocellular carcinoma, and there is emerging data that has demonstrated that treatment with for hepatitis B reduces viral load, integration, and hepatocyte clonal expansion. And I'm going to now turn this over to Tatyana, who can lead the discussion. And thanks so much for the opportunity to present.
Great. Thanks so much, Paul. That was such an excellent overview about really the our current treatment patterns, as well as the implications of treatment and not treatment in these more challenging situations that are perhaps in the gray zone or are in patient groups that are not traditionally targeted for treatment per guideline recommendation. So I'm pleased to start the discussion with Paul, Mark, as well as Jacki, who's joining us as well to share the patient perspective. So, I think one of the big highlights that came out from this, from your presentation, Paul, is really the HCC risk, the risk of liver cancer, particularly in the gray zone, and the mechanistic basis behind it, and how there's emerging data about these early integrations that can occur even in patients who are in the gray zone or immune tolerant that can lead to HCC. So I'm curious, how much of this type of data do you share with patients in your discussion when you have the discussion about treatment? Is this data that you think can help guide the patient discussion, or is this a little bit too much in the scientific realm?
Tatyana, excellent question. And so the answer is I do incorporate this emerging data, not so much about integrations, but I certainly emphasize in the patient population that the hepatitis B is a major risk factor for hepatocellular carcinoma. In fact, I just tell patients this is a carcinogen. And the question is, particularly when somebody has high viral load and these individuals, because their ALTs are relatively normal, they may have been told that there's not much that needs to be done. And I think these data contribute to the idea that what we have been saying over time has been that it's okay to let this viral infection just continue on in the body. And that strategy, I think, over time, particularly as we evolve to better therapies for functional cure that are coming, I think may need to be re-examined, because I think getting the viral levels down and reducing, for instance, integrations, but also fibrosis and all the other outcomes that we can see in these patient populations, I think is going to be the strategy to reduce morbidity and mortality from hepatitis B. And, again, what's in general in this case, the antigen positive, this is a younger population. It is sobering to see deaths and transplant in individuals who are e-antigen positive. These are individuals where I think earlier intervention can improve our clinical outcomes. So I frame the discussion about the risk of cancer and that this is a carcinogen, and it is much better to have no carcinogen in your bloodstream than to have carcinogen present.
Great, thank you. And Jacki, from a patient perspective, what sorts of data is helpful to hear? I guess a similar question that I posed to Paul. I mean, hearing this data about the gray zone and the potential liver cancer risk, but at the same time hearing expert guidelines do not recommend treatment. Does that send a confusing message? And what aspects are most helpful for you to hear when having these discussions?
Well, thank you very much for having me here. It's a very complicated question, but we have as a patient, we have some confusion, especially like, for example, what's the definition of a gray zone? It's confusing because of the number, the measure, the index are changing all the time. So you cannot define today I'm in the gray zone, tomorrow I'm not. I might not be in the gray zone, who can predict the risk? So we have to get rid of the idea of gray zone. I think there's no such thing as gray zone. The patient are infected, then they are infected. They are, we have to rethink about the definition of gray zone, because we don't stay in the gray zone forever, and it changes all the time. So I think this is something that needs to be considered.
That's a great point. So, I mean, you're suggesting that really maybe the approach needs to be simplified, and rather developing new zones, making the message more clear that you have hepatitis B and really there are benefits to treatment.
Absolutely. There's one thing about the, if, for example, there's a question in the Q&A, if it's someone at very young age with very high viral load, we are thinking about retaining those patients in care. And if you don't offer them any treatment or any, you just ask them to come back every 3 months for monitoring, for blood draw, how long can you keep the patient in your clinic? I mean, this is something serious we need to consider to make something that would be benefit to the patient, and then they would be able to be monitored continuously. Otherwise, there's no measure that you can predict the risk when they will become ill. Do you have a number that how long they will be safe if they are 18, 19 years old now? Within 10 years, tell her what's the risk of you will have a serious liver disease within this 10 years. Can you tell them? I think that's something that we need to think about.
Oh, that's a great point. And the idea is that, we want to keep people engaged in care, but if every time they come back and we sort of say, well, we're just watching you, that may not be a way to do that. And then another question, so we have all been very excited about the updated recommendations from the CDC about universal hepatitis B screening for all adults in the US with a triple screen, as well as universal adult vaccination. So really that breeds a more general awareness of the importance of hepatitis B management. So Mark, how do you think that will affect these sorts of discussions moving forward in terms of we're going to be seeing more patients and perhaps more patients in gray zone, and how do you think that will shift our discussions?
Well, first I'd say really important, Paul highlighted that most people with chronic hepatitis B are unaware of their infection. So screening more universally is critically important, and we will see more people in our practice. That's the whole idea of universal screening. And I think here's where the messaging gets complicated. As Jacki alludes to, I'm seeing people in a single point in time, a cross-section of their disease. It will change over time. But if they hear me say, you don't need treatment, everything is good, what they hear is, I'm good. And I may not see them back for several years. On the other hand, if I talk to them about the serious nature of this infection in terms of causing liver cancer and come back with the idea we have treatments that can prevent that, we've now formed a therapeutic relationship where we're working together to ensure that they live a long and healthy life. So I think the messaging is critically important for these newly diagnosed patients that we hope to be seeing in our practice.
That's an excellent point, that really it's that initial encounter that really is a big opportunity to set them on the path for, a better understanding of the condition and the treatment options and what to expect moving forward. So thanks so much. And I think we'll wrap up our discussion for now, and we'll come back to discussion later. But let's move on to our next section. It's my great pleasure to turn things over to my colleague, Mark Sulkowski, to discuss considerations for more expansive hepatitis B treatment. Mark?
Well, great. Thank you. It is really wonderful to have an opportunity to be part of this program. And it really is something that we deal with when we talk to patients about how to navigate the guidelines, which are not always based on strong evidence. So let's get into it, and we'll start with a polling question. So what is your biggest concern for wider adoption of hepatitis B treatment in your clinical practice? A is deviation from clinical guidelines. B is patient hesitancy. C is lack of evidence that treatment is highly beneficial. D, adverse effects of treatment or drug resistance. E is reactivation after stopping. And F is cost effective. So go ahead and vote, and we'll discuss your response. Boy, we've got a whole cross section of responses with 15 to 20% for many of these. But about 20% are concerned about deviating from guidelines and this risk of reactivation after stopping or lifelong treatment. I'll pause there to say that I don't use the word lifelong treatment in my practice. And that's because I'm optimistic, as I'll touch on, that we will get better treatments. So let's move on, and we're going to see another video clip from Jacki about the patient experience. I think it's really important as we think about guidelines. Let's hear the voice of someone living with hepatitis B.
So I realized the reason that I didn't get any care or any treatment, or the doctor didn't really just listen to me, was because of the confusion on their treatment guideline, the professional judgment that they were thinking what was best for me at that time. So I understand in the 1990, when interferon was the only option, and that was up to my decision, my doctor wasn't strongly recommending it. So, and I judge on my own that I feel that I don't want to take that risk for a serious side effect, understanding that the success rate was low. So I didn't take on any treatment or interferon injection. And also based on my condition at that time, that I did not have any symptom and I was doing well. There's no reason for me to becoming ill with the treatment with a little bit of hope to get rid of the virus. And that was the reason that in the 1990 and early 20, I decided not to go on treatment. Although I should have monitored my condition more closely, but everyone is busy when you were in your young age. You were not able to really follow up with a physician very closely. Then, however, the situation have changed. Until now, in the 2020s, we know that there are very good antiviral available with very low drug resistance rate, and people can stay on the treatment for long term. I'm talking about decades or even longer without experiencing any serious side effect. Therefore, I would think that the situation at this stage is very different from 10, 20 years ago, which means that if I would be able to start my treatment much earlier, I wouldn't have to worry about my liver cancer rate because of severe fibrosis, which I have already accumulated over the few decades. Therefore, I would recommend at this stage that the physician would be able to listen more closely to the patient's preference. And if they are willing to commit to the treatment and there's no side effect to the drug, for example, if there's no drug resistance, the patient are fit to be treated, then they should be treated. They should be offered treatment.
Well, that was a really fantastic clip that we heard from Jacki, and talking about the need to involve people with hepatitis B, that is our patients, in our discussions about treatment goals and outcomes. And really, as we'll talk about, in even developing guidelines. Well, let's look at the goals of therapy. Paul highlighted very nicely that viremia with hepatitis B is a risk for liver disease, including hepatocellular carcinoma. So the primary goal of many therapeutic opportunities is to suppress hepatitis B viral load. And we have very effective treatments with first-line oral antivirals that can achieve this in patients with chronic hepatitis B. We would like to see the loss of viral proteins or antigens, including E antigen, if a person is in the antigen-positive state, which is a very valuable endpoint. We know that that changes the natural history. We also want to normalize the ALT. And if one looks over time, people with high ALT are more likely to develop progressive liver fibrosis than those with low ALT. And finally, a lot of attention on number 4, that is a functional cure. That is where the human immune system is able to control the virus and lead to the loss of surface antigen. This is absolutely a major goal, particularly of novel therapies in clinical trials. This is something that does not occur as often as we'd like it to with current oral antivirals. But if we focus on keeping the liver healthy and preventing liver cancer, as new therapies emerge that we'll talk about, we can hopefully achieve number 4 at a higher rate with novel treatments. So I want to look at the idea or the notion of expanding guidelines. What would it mean to bring treatment into some of these different patient subgroups that you see here? I'm going to start with the group in green, cirrhosis with low viral load. I won't touch on this much more, but we know that cirrhosis is a very potent risk of liver cancer. The American guidelines currently suggest treatment in people with viral loads that are low, but it is a conditional recommendation. I'll tell you that in my practice, I treat patients with cirrhosis and a low DNA level. To me, it's not a negotiable state. I won't talk about that anymore, but that's because the risk of liver cancer is very high in that group. You heard a lot of discussion about the gray zone or intermediate patients from Dr. Kuo, and I think he laid the story out quite nicely. And perhaps what I'll say to this is, when in doubt, when we don't have sufficient evidence from the clinical trials, I'll pose the question, is it better to treat in the absence of definitive knowledge, or is it better not to treat? And I'll remind you that we practice medicine, the principle of doing no harm, and as some of the studies we looked at suggest, by treating people in the gray zone, we're actually taking a more conservative approach. I'll come back to that. But I want to focus on this group that is E antigen positive chronic infection, the so-called immune tolerant patient. These are generally relatively young individuals with very high levels of virus who may have relatively normal ALT levels. There's a lot of debate right now about whether or not to approach treatment in this group. You saw data from Paul that these patients are at risk for integration of viral DNA into the human genome, which may increase their risk of cancer. That's occurring while we watch their viral infection. We can also preserve their healthy livers. We know they have minimal fibrosis or scarring. And as Jacki alluded to, if we follow these patients, we may lose them to our clinical care as their lives get busy. And when they come back, much may have changed, including progression of disease. This idea of treatment as transmission prevention, a lot of young people that I talked to about their infections were concerned about transmission to family members, to sexual partners, concerned about even in the workplace, whether their transmission can occur. And this last point about stigma, I think it's really important to understand how the person with hepatitis B lives with that virus. What does it mean to them, and how do they experience stigma in their work and family and community lives? There are, of course, some arguments against that. One is these patients may have high viral loads that are hard to suppress. They have minimal liver disease, so if we're treating, as Paul suggested, an inflammatory condition, they don't have disease. And then there's this idea of committing to long-term therapy. And some of you voted for reactivation risk when stopping nucleoside analog therapy. And this is something that I talk to patients about. Jacki suggested this idea of committing to treatment. I think we do want to understand what the expectations are for treatment with respect to pill taking and how long to stay on therapy. But I think you'll find a lot of people are really open to discussions about treatment. I want to dig a little bit deeper into this idea of the virus as a carcinogen. This is a really fascinating study. There is one group of patients for whom universal treatment is recommended. People with HIV and hepatitis B, we recommend treatment for all patients, so universal therapy. And this looks at a cohort in North America, about 8,354 people with both infections, HIV, Hep B, and 115 cases of cancer. And they asked the question, did viral suppression of hepatitis B influence the risk of cancer? If you look at in the table, people with HBV viral suppression were nearly 60% less likely to get cancer. And if the viral load were above 200, then the risk increased substantially. So in this population, viral suppression in the era of universal treatment reduced the risk of cancer over time. Now, we're eager to see these types of studies in mono-infected patients, but very provocative and compelling data. So what if we did expand the treatment criteria to treat more people? This is a study from Korea where there's a high prevalence of hepatitis B, and there's a couple of different scenarios. I want you to really focus on scenario 3 in green. In this population of patients, about 1.4 million in South Korea, if they eliminated any discussion of the guidelines about e antigen status, so ignore e antigen, ignore whether the ALT is high or low, and just look at viral load. So what is the predicted outcome if we just treated people with chronic hepatitis B and a viral load greater than 2,000? Well, in the first figure, you'll see more people went on treatment. That's to be predicted. In the current model, the base, if you will, there's a relatively small number of people on treatment, and that increases. But look what also increases: the benefit. The number of liver-related deaths declines in the group in green along the bottom. The incidence of decompensated liver disease and cancer also declines. So simply by treating this as a viral infection, we can certainly do better. If we look at the US population, now we get into cost effectiveness. And here's an analysis looking at disability-adjusted life years and setting a cost of treatment at anywhere between $2,000 and $750. And what the models show is if we treat all people with chronic hepatitis B, is it actually becomes cost savings if the amount of cost of treatment annually is $750 or less. In other words, the society saves money. Well, before this symposium, I got onto GoodRx and saw that you can actually buy a year's worth of antiviral therapy for around $200 US. So meeting that criterion for cost savings for treating all. That's not to say cost is not important, but it's not as much of an impact as we might think. So given all the discussion we've had about hepatitis B as a risk for hepatocellular carcinoma, it's no surprise that a number of experts in this field have suggested we simplify the algorithm. You heard Jacki talk about how when he was interacting with his healthcare providers, there was confusion, if you will, about the guidelines. There's confusion about what a normal ALT is. There's confusion about whether it should be 2 times upper limit normal. But in this guideline, the recommendations were relatively straightforward. Cirrhosis, treat everybody. And if you look at the figures, what you'll see is if the viral load is greater than 2,000, independent of ALT, the recommendation was to treat. Now, if the ALT is high, they would treat at any viral load. But you're seeing this greater emphasis on viral load, with 2,000 as kind of the magic number for if the viral load's above that, we want to treat. Other experts, Doug Dietrich, my colleague in New York, incorporated age into this. And this takes into account one of the truisms in life, which is most diseases tend to increase in severity over time as we get older. And we know the liver cancer risk increases as one gets older. So here, if you're older than 30 and the viral load is greater than 2,000, treat at any ALT. This is very similar to some guidelines recently adopted in China, where they said any detectable virus level. Under 30, the ALT comes into play, and you'll note they're using relatively normal ALT and AST levels. So these are some expert-based guidelines that are being discussed. And on a global stage, where there are nearly 300 million people with chronic hepatitis B, the WHO is in the process of updating their 2015 guidelines. And one of the goals of the WHO activity is to really expand and simplify how we're approaching antiviral treatment for people with hepatitis B. So expanding treatment criteria, really looking at 2 groups of patients with a laser focus. One is the so-called immune tolerant patients. These are the hepatitis B e antigen positive, high viral load, chronic infection patients that we talked about. And then this gray zone population, I think, is something that we're definitely really beginning to focus on. So they're going to expand the guidelines. We look forward to the publication. Now, I want to bring up another topic, which is the importance of bringing in people with chronic hepatitis B into the guidelines discussion. We talked about ALT levels, viral loads. Well, how does the patient view living with Hep B? We know there is fear of progression, there is concern about transmission and stigma, and there's concern about physical well-being and health. Really important to engage the patient in shared decision-making. And even to engage patients in guidelines, rather than have a group of experts sitting around a table or now a Zoom room talking about which patient should be treated, we certainly will want to think about their perspective as we integrate what's valuable to patients, as we integrate things like transmission or stigma. And talk about how we translate these guidelines to actual clinical practice. So the need to include people with lived experience in guidelines. Now let's just talk briefly about the current treatment strategies. Jacki covered interferon quite well, and it hasn't changed. It's still pretty significant in terms of its side effects. But let's look at long-term treatments with entecavir, tenofovir. You can see here we're going to suppress virus levels, and we're going to look at high rates of viral suppression, and really, most patients are treatment candidates. One of the things I've heard people talk about is the low rates of S antigen loss. Certainly in my practice, I've been practicing long enough, I do see S antigen loss, but I tell patients, we're going to keep your liver safe and healthy and reduce your cancer risk while we work on novel therapeutics. I won't go through the details of this slide, but we are at a very exciting time in the development of antiviral and immunologic approaches to treat hepatitis B. There's a tremendous amount of science looking at the viral life cycle depicted on the left-hand side of the slide, how the virus enters the cell. We now have entry inhibitors like beloveritide that block the NTCP receptor. We're now looking in clinical trials at medications like small interfering RNAs and ASOs, antisense oligonucleotides, that can block the translation of viral RNA. Really very important. So while this is going to take some time, I tell my patients, let's keep your liver healthy while the science moves forward. All right, so let's go to our assessment number 2. So after participating in this program, how likely are you to recommend treatment for a 38-year-old non-cirrhotic who has a normal ALT and a viral load of 3,000? And you can see the options there. So go ahead and vote. How likely are you to treat this patient with a viral load exceeding the 2,000 threshold? So certainly the majority of you are in the likely and extremely likely category. So that's fascinating. We'll discuss that a bit more in the Q&A at the end of the program. But let me go ahead and wrap up my thoughts for my section here. So based on newer algorithms, we want to see people greater than 2,000 independent of ALT being treated. So we'll talk a bit more about this, but fantastic. So the take-home points. There is a huge effort underway to expand HBV treatment. Focus on lowering the risk of long-term complications and focus on the virus. This 2,000 threshold is gaining traction as a metric in which to decide whether someone needs treatment, shifting to a viral disease, not an inflammatory disease. We do want better evidence, but our patients and people with hepatitis B can't afford to wait for these trials to be funded and conducted because that may never happen. So finally, I want to highlight the shared decision-making that Jacki so elegantly suggested to us in the clips, and I'm going to turn it over to Tatyana to lead us through some discussion.
Great, thank you so much for that excellent overview. And really, I guess to hone in on one of the initial points that you made, that you do not use the term lifelong for patients, but at least some of the patients that I see are quite really want the details. So if not lifelong, then for how long, and what could be the other endpoints that we're looking for. So how much do you share about this idea of functional cure and other endpoints that you may be targeting?
So I always, with patients, share my excitement and enthusiasm for the scientific advances and the clinical trials being conducted in hepatitis B. They may not want to participate in a clinical trial, but I want them to know that the world is pushing forward with novel therapies to target the virus in the immune system, with some medications, one in particular, entering phase 3, which could be here in 2 to 3 years. So I want them to hear my enthusiasm for higher rates of functional cure within a 5-year period. And then if I expand that to 10 years, I think we're going to have many more options, particularly as we advance the science of cell engineering.
Great. So you give them that 5 to 10 year horizon, and really that sort of becomes kind of a surrogate endpoint potentially for patients in terms of their treatment plans. Great, thanks. And then Jacki, so I know we really highlighted here the importance of joint decision-making, shared decision-making, but to what degree do you really want your doctor to tell you, well, this is what you need? And to what degree does opening this can of worms actually make this more complicated to say, well, now I have to make the decision. Aren't you the doctor who should be telling me what to do?
Exactly. I'm also an advocate. So we have a patient group, and we have a very hard time to convince our patient not to listen to their doctor. They have to listen to their doctor, obviously, and that's very important. That's why the guideline is so important, that the patient would listen to their doctor, not to us. So it's very important that you have a consensus so we can advocate. Otherwise, we will be in direct conflict with the doctor's recommendation. Now, there's one point that I want to raise, if it's okay, for just one simple question on the proposed algorithm. I really like the simplified algorithm, and the thing that I like particularly is to treat everyone with cirrhosis. You have that for a long time, although it has been challenged recently, but to treat everyone with cirrhosis is one great idea. And taking that idea, however, what is missing is that you have to consider, if I'm in F3, if I'm in F2, now you should treat us as well. This is the fibrosis is progressing, the liver, the virus doing the damage to the liver. You cannot, if you would change that cirrhosis into F2, treat everyone that has liver fibrosis, it's been damaged by the virus, then you should treat them, get rid of the virus at any viral level without, because the viral level would change, right? So at any viral level, if you have F2, then treat them, or at older age, like the second proposal with age above 30, for example. That's right. Just my
no, that's true. And even our more conservative guidelines, really do highlight that if you have F2 fibrosis or higher, you really should have a lower threshold for treatment. So very much, I agree with that.